Hello, my name is Patrice McLeod, and I'm here to present my capstone project to you, the use of telecommunications to reduce heart failure readmission rates. So let's get started. So to begin with, there are over 5 million people in the United States living with congestive heart failure, or CHF, as we denoted. And there are many things that accompany CHF, but non-medically, um, the biggest cause of concern for those population of patients is their readmission rates. So when you think about hospital readmission rates, there are three. The top big three are pneumonia, heart attack, and heart failure. And amongst those three, heart failure is the leading cause of readmissions for adults age 65 and older. So if you look at the side, did you know on the brochure, heart failure readmission rate is the highest at 20 to 25% within the first month of discharge than any other medical condition. And when you think of heart conditions in general in the United States, heart related deaths are the leading cause of death in the United States, with that being higher than even cancer. So it's a major cause of concern when we think about this population of patients and how do we best care for them in the best ways possible, the best evidence-based practice methods. Looking in this research, it was my duty to, just delve into the evidence-based practice protocols that are out there in the literature to see what is the best way we can address this issue of readmission rates within this population. So next, congestive heart failure, as I stated earlier, is the leading cause of rehospitalization in our elderly population. So we know that there is an opportunity for improvement in this area. So when you think about healthcare in our fragmented system as it is, we need to really improve upon how we better educate our patients, how we get them to comply medically, and just lowering their costs overall in terms of hospitalization. So I looked into, the telecommunications program as a best practice method, as well as a best practical method to introduce evidence-based practices surrounding this issue to our hospital system. So let's look into the actual program. I'm going to go down to the second page of the brochure. So the program, telecommunications or post-discharge phone calls, is the new wave of the future. Healthcare is vastly delving into remote patient monitoring as a method to care for our patients. Like I said, the new wave of the future. So in doing that, we're going to be using our remote patient monitoring to care for our patients in their own setting, reducing their non-compliance by not coming to the hospital or not coming to doctor appointments and things until things get too late. So the nursing interventions surrounding this program will, as you can see, increase medication management, capture early exacerbation symptoms, and it will continue heart failure education. So let's break those down one by one. Increasing medication management. So as you know, taking your medications as they're prescribed at the right dosage at the right times are very, very important things when it comes to heart failure management. So it is important, as we do during our MedPass times in the hospital, explain to the patient what medications they're taking, why they're taking it, the time in which they should take it, and also some symptoms involved around what happens when you take this medication. These are all things that increase compliance. I'll tell you, there are certain classes of medication like lisinopril. Some of the signs and symptoms of taking that kind of medication is a cough. And so when patients notice over time, I haven't taken this medication or I haven't been coughing only until I take this one, they may stop taking it, which reduces their compliance and also puts them in a bad situation medically, which will bring them back to the hospital in an exacerbation mode. Next, capture early exacerbation symptoms. So if you look in the middle column of the brochure, signs of fluid overload are swelling in the lower extremities, weight gain of more than 2 pounds in a day or 5 in a week, the inability to lay flat, and feeling short of breath. So when I was thinking about this program, there are certain things surrounding the program that are key into identifying these types of things when it comes to our patients. So Right now, the usual care model, when you're thinking about discharging a patient home with heart failure, number one, you have to educate them in the teach back format. And when you do, there are 6 areas that the Joint Commission on Quality and Safety recommend an audit to see if the hospitals are actually discharging these patients in this manner. So it's on diet, exercise, worsening symptoms, weight management, follow-up appointments, and their medications. So in looking at those 6 things, that's a lot of information for a patient to, number one, be educated on, and to retain that information to just go about living their lives in the most compliant way possible when you release them from the hospital. So when thinking about that, just think, you're in a hospital in an acute exacerbation mode. You're sick, you don't feel well. Are you really retaining the information that we're giving you? It's a very large amount of information. So it's very important for us to continue that education in an outpatient setting where they're actually doing the care for themselves. It's very easy for someone to educate you and they're doing the work. As nurses, we are doing the work while they're in the hospital, and we're telling them what we're doing in hopes that they're retaining it and picking up those jewels of knowledge that they will take home and do for themselves. But it's even more, in my opinion, valuable when you're teaching a patient in their home environment when they have to do it themselves. So getting back to capturing early exacerbation symptoms. So in the hospital, before a patient will be discharged, if they're going to go by protocol of this program, the nurses will fill out some signs and some high-risk behaviors that maybe the care coordinator that will manage these post-discharge phone calls maybe needs to look out for when they are talking with the patients at home. For example, if a patient's not um, compliant with their fluid management, maybe the doctor has them on a 1200 limit, and you notice in the hospital that every time you turn around, the patient wanted more fluid and more ice, and they were not compliant with that. Those are some signs and things that they need to look for in the outpatient setting. So that's one of the things that one of the tools that we'll get into later when we talk about the program and how that transitions from hospital to home, that the care coordinator will look at. So just making sure you're very aware, asking the patient, when it comes to capturing the early exacerbation symptoms, have you weighed yourself today? Do you feel short of breath? Did you sleep in the bed, or did you sleep in a recliner last night? Did you use an extra pillow? These are all things that are telling the care coordinators, hey, this patient may be heading towards a volume overload. And stopping and mitigating those symptoms in an outpatient setting rather than allowing them to get worse to be handled in an inpatient acute care setting. And lastly, like I said, continuation of heart failure education. It's very important for us to be mindful that heart failure education is not just a hospital thing and then you're done. We need to continue that education. The patients, is in their best interest to learn, you know, about these things in their own setting when they're feeling better and they're not sick. So like I said, just educating them on their medication, making sure you're telling them about looking for those symptoms for exacerbation, having them to just follow up with their follow-up appointments, and making sure that they actually have modes of transportation to get there, and no extenuating factors that prohibit them from complying with their care. It's very important to do that in an outpatient setting as a way and a means to reduce heart failure readmissions. So what are some best practice methods that surround this program? So to begin with, let's recap the program. This will be a program that patients voluntarily sign up for that will manage their symptoms and continue their education for over a 30-day period. And it is our hope that with talking with somebody, the same person, or maybe the same group of people within a 30-day period every day, you will better gain knowledge on how to manage your condition, manage your symptoms, and most importantly, not readmit to the hospital within that 30-day period. So patients and nurses both, if you look at the last column on this brochure, it's their roles in this telecommunication phone call program, that the patients, number one, as a criteria, be able to have a working phone, physical dexterity to actually use the phone, and they are neurologically intact. Next, patients that are willing to adhere and participate. We know that patients have a right to refuse, and not all people would want to be involved in this program. So we're not going to force this program on anyone. We do want to give them an option to have it. It will be in their best interest to maybe participate in it so that they can, smoothly transition home. And I think it would be a great way for them to, gain that confidence it is to conquer heart failure. And then next, the patients will have to communicate all of their symptoms. So, like going back to what we said about fluid overload, if they felt short of breath, hey, today I feel more short of breath than I felt yesterday, or today I didn't get a chance to take my first medication, what do I do? Patients need to communicate all things to the care coordinator so that they can better help them in this setting. Next, monitoring their symptoms for over the 30-day mark. So the 30-day mark is very important because when a patient is discharged, if they come back at any point within the first 30 days, it is counted as a readmission. In this way, that's when the Centers for Medicare and Medicaid can, opt to refuse reimbursement or impose those regulations that are new in place on the healthcare facility that is taking care of the patient. So it's in your best interest to properly educate the patient, give them all the tools that they need so that they don't come back within 30 days. And it's not just beneficial for the hospital, this is beneficial for the patient because, them having to come back to the hospital, they are leaving behind work and they care for their kids and all sorts of things at home while they're there in acute care. So, we want this for our patients as well as our hospital institution as a whole. And lastly, our nurses will be measuring physiologic data on an electronic device. So we'll be tracking and trending everything that's going on with the patient, whether they're compliant with taking the meds, are they compliant with looking for these signs or symptoms, have they been to their follow-up appointments and disease management programs. And, all sorts of things will be tabulated and given to the primary care provider as well as another tracking tool to give back to the hospital if they return within that 30-day mark. So we know, this program overall, the overwhelming results support that telecommunications post-discharge phone calls do reduce heart failure readmissions. And the evidence showed by 20%. For all who enrolled in this particular type of program. In addition to that, it showed a 21% mortality risk reduction in heart failure patients, which is very important because we know that heart failure, with the progression of the disease, can kill you. So reducing that risk by 21% is phenomenal and outstanding. So not only are we helping the patients not re-enter the hospital setting, we're giving them the tools to care for themselves in their own setting, to not have to miss work, and also we're reducing their mortality risk by 21%. I don't think you can get much better than that when it comes to taking care of your patients in this particular type of setting. So I think that this program is astounding, it's very important, and it's very practical. When you think about introducing evidence-based practice to a hospital, it is always very scary because no hospital really wants to spend the money it takes to implement these large programs if it's not going to recoup financially. But for me, I don't think that this will be different because we already at hospitals have care coordinators, which are responsible not just for heart failure after all admissions to call patients to make sure that they are making it to their follow-up appointments. And if not, what are the barriers that are inhibiting them from getting there and kind of making a smoother route and for them to make these follow-up appointments. So we have systems in place. All we have to do is retweak those programs to, have a group of people that are dedicated within the care coordination department to call for a 30-day period these patients to make sure that they are complying with all of these regimens as we stated, increasing their medication management, capturing early exacerbation symptoms, and continuing that heart failure education to keep them out of the hospital setting. So with that, I would like to conclude. Thank you so much for listening to this presentation, and I hope that you can take away with you that this is a great program to implement right here in your very own hospital. Thank you. My name is Patrice McLeod, and have a great day.